Good evening, all. This is Badal from IDCP. Welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. He is none other than a very renowned anesthesiologist, Professor Dr. Nishant Kumar, sir. Sir has not come to our platform for the first time. Indeed, whenever he is here at our platform, it is a pleasure and honor for us to have him with us. Sir is DA, DNB, MNA, MS, professor at the Department of Anesthesiology at Vedic Medical College and associated hospitals. With the help of Sir, we'll be taking a close look on today's topic, which is fluid management in critical illness. Before moving on to today's session, let us have a brief look on what the topic says. Fluid management in critically ill patients is a crucial aspect of their care as imbalances in fluid status can have significant implications for their overall clinical condition and outcomes. We'll be learning more about the key consideration and strategies for fluid management in critically ill patients with Sir's wonderful inputs that he'll be pondering upon today. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk today. So over to you.
Good evening, everyone. Thank you, Vatul, for the kind introduction. So, today's topic is fluid management in critically ill. Now, fluid administration in the ICU is probably one of the most disputed and contested topics that you could come across. So, it starts with when to start fluids, which fluid to give, how much of fluid to give, how to assess whether more fluids are needed or not, and when to stop giving fluids and when to withdraw. So, fluid management is not just a challenge or resuscitation. I mean, it is not just limited to a fluid challenge or a resuscitation. It is an ongoing process which has to be discussed and modified as the patient gets better or during his entire stay in the ICU. Remember, fluids are drugs and should be treated as such. They have their own side effects, and each fluid has its own nature and indication and contraindication. Remember the 4 Ds for fluids. That is the drug, that means the fluid, the nature of fluid that you're giving. So the indication, contraindication, and resultant side effects in the critically ill patient. The dose, how much to give, at what rate it should be given, duration, when to start, when to stop, and de-escalation, that is when to withhold and when to withdraw or remove the fluid from the body. So these 4 Ds are very crucial. That is drug, dose, duration, and de-escalation, and that is how we'll proceed with the debate with the discussion on fluid therapy in the critically ill patients. Now we know that we have a multitude of fluids available at our disposal. So these are the crystalloids and the colloids. So we should know the indication, contraindication, side effects of each fluid which is there. The most commonly used is the lactated ringer solution. Then we have the balanced salt solutions which are coming up, which is acetate ringers, plasma light, stereofundin, and so on and so forth. We have the gelatins, isoplex, and gelaspan. Then we have the stretches, the hextend, tetraspan, voluven, and many others. Now, it is very important to know what is the composition of each and every compound that you're using, just like you're using any other drug. So you should know the exact composition of the fluid, and the fluid that is best suited to the patient's pathology should be used. Now, I cannot say that, okay, it is this condition, you use RL. If it is this condition, you use plasmalite. If this is this condition, you use stereofundin. The choice of the fluid will depend on the patient's underlying pathology, underlying electrolyte imbalance, and the status of the patient, the fluid status of the patient, and the stage at which the patient presents, as we'll discuss a bit later. So remember, you have to choose which drug or which fluid to use depending on its composition, indication, contraindication, and side effects. Now, as I said, the fluid can be administered during the resuscitation phase, maintenance, replacement, nutrition, or all of these may be going hand in hand. So, remember, as I said, that you have to decide at which phase you'll be using which drug. Now, each the same fluid will depend the dose and the rate, and the side effects will vary according to the state that the patient is in, or for the indication that the fluid is being used. Resuscitation, you might have to give a large dose in a short period of time. Maintenance, again, will depend on the requirement of the patient. Replacement, again, how much losses the patient is putting out. And for nutrition also, the nutritional status of the patient, and never underfeed or overfeed the patient. And all these will go hand in hand. So you might have to use a combination of fluids to maintain all these stages. Now, this is just a pie chart describing the different fluid types in the ICU and for what indication we are using. So, as you can see, 33% is nutrition, that is where the fluids are used for. 6% for resuscitation, 25% for maintenance of replacement, blood products as and when required, that is mainly your losses, and mean cumulative daily fluid rate according to the Western standards has been calculated as 114 ml per hour. So that is roughly 2 ml per kg per hour for a 50 to 60 kg patient. Now, the most important thing is this part. 33% of fluid creep, which can and should be taken care of, and this is the most important part which we neglect and leads to a fluid overload. So this 33% fluid creep is the fluid that we give along with the drugs, the infusions, the diluents, or the boluses that we give, which unfortunately remain unaccounted for, or at the end of the day, when we are tallying the positive, the input and the output, then we realize the input is much more than the output. Now, what would contain describe as an ideal resuscitation fluid? We all know that homeostasis, the interstitial space is small, but because of severe sepsis, septic shock, the inflammatory markers, there is endothelial permeability, and water leaks into the interstitial space, as well as there is a dysfunction in the lymphatic vessels, which leads to less reabsorption and again leakage of lymph water or fluid from the lymphatic vessels into the interstitium. So currently used resuscitation fluids like NS will increase inflammation, enhance the endothelial injury, and increase edema. An ideal resuscitation fluid should ideally decrease inflammation, reconstitute the glycocalyx, repair the endothelium, decrease the endothelial permeability, have some amount of endomicrobial activity so that there is less edema and less cumulative balance. Now, the fluid choice for resuscitation. There have been many trials that balanced salt solution is preferred over sodium chloride. So, we all know that sodium chloride will cause hyperchloremia, might cause hyperkalemia as well. The SMART trial has shown, again, there's a controversy which one, some say NS is better, some say balanced salt solution is better, but then the consensus at this point of time is that the balanced salt solution is better not to use dextrose. Starches are to be restricted, can be given in hemorrhagic shock, but more or less it should be limited in sepsis because they cause what is known as global increased permeability syndrome. So they may actually be harmful. So unless until you're waiting for the blood and the patient is crashing, you can go in for starches, but otherwise stick to crystalloids and preferably balanced salt solution. Albumin, again conflicting reports. Some say if you give albumin early in sepsis, it is beneficial, but the only indication of albumin in sepsis is probably hypoalbuminemia. Now, there are certain myths of fluid therapy. Now, there's a myth that all septic patients are hypovolemic, which is not true. Low preload does not always warrant fluids. Sepsis is not equivalent to increase in sensible losses. All surgical patients may not be hypovolemic, and in cases of edema, don't overzealously give diuretics. Now, we all know that fluid overload has a lot of problems. We have the respiratory problems, increased chances of pulmonary edema, pleural effusion, chest wall elastance is altered, PO2 is decreased, PSO2 increases, decreased PO2 or 5O2, extravascular lung water increases, lung volumes decrease, prolonged ventilation, difficult breathing, work of breathing, so on and so forth. Central nervous system, if proper osmolality is not maintained, cerebral edema, increased ICP, decreased CPP, increased IOP, cardiovascular myocardial edema, conduction disturbance, impaired contractility, increased POP, decreased venous return, decreased stroke volume, hepatic congestion, impaired synthetic function, increased cholestasis. Similarly, for GI, ascites formation, gut edema, malabsorption, ileus, decreased bowel contractility. We have tissue edema in the abdominal wall, poor wound healing, wound infection, pressure ulcers. We might have something called as abdominal compartment syndrome, renal interstitial edema, increased renal venous pressure, which leads to decreased renal blood flow, and salt and water retention, uremia, decreased GFR. So all these are the problems of fluid overload, and it should be prevented at all costs. So while resuscitation, these are the things that you have to be careful about, that you should not overzealously overload the patient. Now, when we talk of maintenance fluids, it should cover daily needs. So a rough guide is water, that is a carrier fluid, 1 ml per kg per hour or 25 ml per kg per day is the basic requirement. Some say 2 ml per kg, but you start with 1 ml per kg per hour and then you can increase up to 2 ml per kg per hour for incremental losses. Glucose 1 to 1.5 gram per kg per day, sodium 1 to 1.5 millimoles per kg per day, potassium 1 millimole per kg per day. I would like to add in this is magnesium and calcium. Remember, 1 gram of magnesium is required for daily needs. And always remember that hypomagnesemia is one of the most common electrolyte deficiencies in the ICU, and it increases with prolonged stay. So please don't forget your magnesium, and again calcium. Don't go by total calcium levels because the albumin might be low in these patients. So please go in by your ionic calcium levels. The replacement fluids and nutrition fluids. Replacement fluid should mimic the fluid that is lost. For example, give saline or ammonium chloride in cases of GI losses. Now, GI losses are the only indication for saline. You have to give isotonic replacement in case of burns, and you have to give bleeding when the patient give blood when the patient is obviously bleeding, or component therapy in cases of coagulation disorders. Nutrition fluids should cover caloric needs, and it is usually overlooked because of fluid accumulation. Now you have to restrict fluids. The axe falls on nutrition. Please remember that you can cut down on replacement fluids, you can cut down on maintenance fluids, but please cover the nutritional requirements of the patients. That was the drug. Coming to the dose. So, what is an effective dose of an IV fluid? That will depend on what is the exact desired therapeutic effect that you want. Again, the therapeutic window can be quite narrow in certain patients. For example, patients in renal failure, for patients with congestive heart failure. So remember, therapeutic window will have to be individualized. Now, again, what is the desired therapeutic effect that you want? You want to target a map of more than 65 mmHg? Fine, you target them and then stop beyond that. So, as they say, that the fluid challenge specifically for resuscitation should be optimized. Surviving sepsis campaign guidelines say 30 ml per kg. That doesn't fit all. Okay. The corollary is you give a mini fluid challenge 100 ml of colloid, but again that might not be good in certain patients. So you give around 4 ml per kg of crystalloid as a mini challenge over 15 to 20 minutes, over 30 minutes. And you have to monitor whether the patient, first of all, is fluid responsive or not. So, prediction of fluid responsiveness, always remember, please do not rely on static parameters. Static parameters are your CVP and capillary wedge pressure. Rather, you rely on pulse pressure variation or stroke volume variation. For that, you'll require the newest gadgets. You can use inferior vena cava diameter variation. So collapsibility and distensibility index. Again, there are certain limitations for these this thing. You can even use SVC diameter variations. The most simple and easy to do is the passive leg raise. Now, thing is that you make the patient supine. You raise the legs of the patient at the hip joint by 45 degrees. You keep them raised for 90 seconds or so. Now, if you see a change in stroke volume variation or a pulse pressure PPV of more than 5%, that means that the patient will require fluids. There are others also. You have the high tidal volume challenge also. You have the end expiratory occlusion test patient also. But then again, end expiratory occlusion test cannot be used in non-intubated patients, and you have to have a respiratory hold for that. Again, mini fluid challenge, you can give 100 ml. Again, you need the cardiac output monitoring, and um, away conventional fluid challenge can be given. You have the ETCO2 monitoring, which can guide you. If the ETCO2 rises by 5 to 10 mmHg, then that means that the patient was actually responsive to fluids. So there are many things how you can predict fluid responsiveness. That is another topic for another day, because that will take another class for that. And hopefully, if you all people want, I can take that in the next class. How to predict fluid responsiveness? What are the parameters for fluid responsiveness? Now, a simple flow chart. Is there acute circulatory failure? So that will be given by low blood pressure or cardiac output. Very simple. You need to have an invasive arterial monitoring or signs of tissue hypoperfusion, as in raised lactate. But again, raised lactate may be spurious because of certain metabolic conditions. So is hypovolemia obvious? Surgical patient bleeding, yes, obvious fluid loss, or an initial phase of septic shock. So yes, perform volume expansion. In this, when there is an obvious hypovolemia, please go in for a volume expansion. But if you feel that not sure whether there's an obvious fluid loss, okay, this might not be an initial septic shock, but the stabilized phase or this thing. So then you see the preload responsiveness. You see whether the patient is spontaneous breathing, whether they are cardiac arrhythmias, or the patient is having ARDS with low tidal volume lung compliance. Then you can probably, if these conditions are there, then you can use the passive leg raise, an expiratory occlusion test, or a mini fluid challenge, because these conditions will limit your pulse pressure and stroke volume variation, the IVC and SVC diameters, and expiratory occlusion test, and mini fluid challenge. So these things basically, and it's this PPV, SVV, and respiratory variation will not be present. Will give you a false value if these conditions are present. So passive leg raise and expiratory occlusion test if the patient is intubated, or a mini fluid challenge can be used in both the conditions. Okay, so if these conditions are met, if these tests are positive, you consider a volume expansion. But again, you have to be careful not to overload the patient. If these conditions say the tests are negative, please do not give a volume expansion. Think of other causes of MAP. So next thing is duration. When to start and when to stop. So this is an comparison of three studies. So we have the early adequate and late conservative, early adequate, late liberal, early conservative, late conservative, early conservative, and late liberal. So if you see, it is the adequate and the conservative fluid therapy which is giving the least mortality in ICU. So giving more fluids is harmful, period. You can err on the side of less, but then that will also, it's a double-edged sword. You might end up with hypoperfusion, increased lactate. So the best thing is, rather than being conservative or being liberal, the best thing is that you have to have an adequate duration and adequate amount of fluid which should be given. Now, another important part is the de-escalation. You should know when to de-escalate your fluid therapy. Now we'll come to this concept of ROSE in a minute. It's a very easy mnemonic to remember. Resuscitation, optimize, stabilize, and evacuate. Right? So if you see this, during resuscitation, you give a large amount of fluids. Okay, optimization and stabilization, there's a plateau, and evacuation, you take out the fluid from the body. So if you see the chances of organ failure, it is hypoperfusion, the highest. Then once the resuscitation is over, it is low. And now during the optimization and stabilization phase, if the patient goes into positive balance, again the chances of organ failure increase. And then as you remove the fluid, the chances of organ failure decrease. But if you decrease this too much, then again the chances of organ failure increase because of perfusion. So it is neither the conservative nor the liberal. You have to just give adequate fluid therapy. So the resuscitation, now this is what we call a mnemonic ROSE. Resuscitation is aim of the fluid treatment is resuscitation and correction of shock. So as to achieve an adequate perfusion pressure. During optimization, fluid should be administered according to individual needs and reassessed on regular basis. Regular basis could be as small as 4 hours, it can be as small as 2 hours. Now, most of the times I've seen that the residents write the orders in the morning and the fluid balance is seen the next day 24 hours later. You have to keep on constantly seeing your input output. You have to keep on seeing the fluid balance and modify your fluids accordingly. During stabilization phase, we provide water and electrolytes to replace ongoing losses and provide organ support. And during evacuation, we remove the excess fluid from the body. This is by spontaneous diuresis. Now, diuresis, the patient goes into diuresis. That is a very good indicator that the patient is recovering. Don't confuse it with forced diuresis with latex, which is very commonly given. So they might be necessary. A renal replacement therapy might be necessary, but spontaneous diuresis is always a sign that the patient is recovering. Okay. Please discount the neurological conditions where you might have SIDH or diabetes insipidus, but in general, I'm talking of septic patients. So basically, ROSE can be again resuscitation is again stabilization to prevent hypoperfusion. Optimization is the same, stabilization is the same, and then de-escalation. So SOSD has been converted to ROSE. Resuscitation, optimization, stabilization, and evacuation is same as de-escalation. So that is another mnemonic, but ROSE is uh, easier to remember. Okay, so you have early adequate fluid management, late conservative, then you have the late goal directed fluid removal therapy. So these are the things that you have to remember, that early adequate, not excessive. Okay. Then you have the late conservative. The idea is not to have a positive balance at any given point of time. So that is the whole thing. Now, if you see resuscitation, there's a severe shock, fluid balance is usually positive. During the optimization phase, it is neutral. Stabilization, it might be neutral or negative. And during evacuation, it should be negative. So goals in the resuscitation phase are to correct the shock. During the optimization phase, it is maintain tissue perfusion. During stabilization, aim for zero or negative fluid balance. That is the late conservative fluid management. And during evacuation phase, you have the late goal directed fluid removal, that is emptying or de-resuscitation, and you mobilize the fluid accumulation to maintain the tissue perfusion. Now, just as we are conservative with our antimicrobials, it is time that we introduce something which is called as fluid stewardship. So we have to see whether the fluids are routinely necessary. Has patient reported thirst? You have to see. Now, you develop an algorithm that accounts for serum electrolyte concentration, comorbidities, and and the phase of fluid administration to aid in IV fluid selection and dosing. Osmolarity or the osmolality of the fluids that you're giving. Consider the role of albumin. Um, Now there is a controversy, maybe the pharmaceutical driven. They say that balanced salt solutions are better than Ringer's lactate. We don't know as yet. Trials are yet to come in, but yes, evaluation of medication stability in balanced IVF diluents. So the creep that I was talking about earlier has to be monitored. The route, whether oral or IV, whether the oral would be better or not. Oral is always better. And daily fluid balance, how the patient behaves when you give oral or IV fluids. Then dose, what dose, whether you give a mini fluid challenge, you give 30 ml per kg, actual ideal adjusted body weights. So all these are the considerations that you have to take into account when we talk of fluid stewardship. Other things will be, how do you monitor the adequacy of IV fluids? What signs may be used for early identification of evacuation phase? What is the optimal timing for initiating interventions for fluid mobilization? How do IV medication concentrations and electrolyte contents affect daily fluid balance? Now that will depend on the underlying pathophysiology of the patient, right? So comparative incidence of hypervolemia in daily versus twice daily fluid balance assessment. As I said, most of the ICUs and most of the residents they say, okay, we'll do it once a day. Will twice daily fluid balance assessment benefit the patient? Remains to be seen. So these are all the things that can be included in your ICU towards fluid stewardship. So we have a snapshot of fluid consumption. We have the survey doctors, survey nurses. We perform an audit. On the basis of audit, the feedbacks are provided. We form the flyers, posters, screensavers. We teach, and then we have the stewards who have knowledge and who can actually personalize fluid therapy, and we can go into towards fluid stewardship. So, what is the future? Ideal fluid, the search still continues, but what we know so far is that normal saline is not so normal. Problems are hyperchloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretion, and increased chances of AKI. So, balanced salt solution, split and salt trial, no difference. Smart trial, they said that balanced salt solution is better, mortality is low, vasopressor free days, adverse kidney events are low, but limitations as compared to RL and NS, definitely costly and availability. So that is one of the limitations of balanced salt solution. Albius trial, they said that 2014, they said there was no difference whether you give albumin or not, but somehow it had shown a slightly better effect in septic shock. Again, the verdict is divided whether to use albumin in septic shock or not. But yes, in the presence of hypoalbuminemia and certain conditions such as burns and probably the TBI, it can be considered. The gelatins, no difference in mortality and other effects. 2015, they showed that there was an increased incidence of RRT, but then again, the strength is not very good. 2016, they showed increased anaphylaxis, but again, the evidence is not very strong. But then, something which can be met by crystalloids by going for gelatins. So, for sepsis, please prefer balanced solutions above 0.9% saline, crystalloid over colloid. Okay, and fluid overload with crystalloid is not an issue. Why? Because the half-life of crystalloid is low. For colloids, it's longer. So if you balance them, you'll be probably the intravascular wall mix section will probably be remain the same. Albumin in the presence of hypervinemia reduces mortality, but again the strength is not very strong. ARDS have to maintain a conservative strategy. Overall fluid balance is more important. Try to maintain a slightly negative or a neutral fluid balance, positive balance. So, major abdominal surgery, we assume that the preoperative fluid balance is in excess of 2.5%. Colloids may be used intraoperatively till blood products are awaited. It may be beneficial. And in case of urgent surgery in the presence of sepsis, please follow the same rules as for any other major abdominal surgery. For trauma, crystalloids remain the first choice. Amount has to be restricted. Colloids can be used if crystalloids fail to maintain MAP. Again, balanced salt solution is preferred as compared to normal saline. For traumatic brain injury, the safe TBI had its limitations. 5 to 20% albumin or hypertonic saline, keeping in view the principles of Lund, may be beneficial. For burns, balanced crystalloids are the first choice. 5 to 20% albumin or colloids to maintain osmotic pressure if the burn area is too high. Remember, all things are poison and nothing is without poison. The dosage alone makes it so a thing is not poison. Fluids are also drugs, and please use them like a drug. If given too much or too less or incorrectly, they are nothing but poison. Thank you, and I'm open to questions.
Thank you so much, sir, for your wonderful talk that you present upon the topic today. We have received few questions from the participants. With all of your permission, I would like to put it across to you.
Yeah, please.
The first question is from Dr. Mathana Gopal. Dr. Mathana Gopal question is, what is the fluids management in critically ill patients?
I think the entire talk was on that.
Yes, absolutely.
How to manage fluids in the ICU. So I think that question should have been answered by now. It will depend on the pathology, when to give what fluid at what days. See, remember the 4 Ds and the Rose principles. That's all I'll say, just to summarize.
We'll move to the next question, sir. And the next question is, what is the physiological role of electrolytes contained in the plasma?
Okay, so basically, you know that the oncotic pressure is maintained by albumin and the electrolytes present in the fluid. Otherwise, the tonicity is maintained by the electrolytes. So the idea is the main aim in an ICU is to maintain homeostasis. So whatever is lacking, you replace it. Whatever is in excess, you correct. So that is the basis of all electrolyte imbalances.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, when clinicians should be more careful in fluid administration?
At all points, you can never be careless about fluid administration. As I said, too less is harmful, too much is harmful. So it has to be just adequate. So remember, these are drugs. You cannot underdose or overdose. You cannot restrict it to 1 day or 2 days. You cannot go on giving fluids forever. So at all times, you have to be careful.
Thank you, sir, for answering this question. We'll move to the next question, the last question for today's session. And the question is, does an increase in cardiac index after fluid administration means improving the DOT? DO2.
Sorry, DO?
DO2.
DO2. Okay. Now, again, we assume that it is so. We assume that once the map, see, that is how the concept of map, again, now the concept of map is not so. We are moving on to flow rather than pressures, because now they say that pressures are again a static variable rather than the flow, which gives you a continuous measurement. So we have the hypertension prediction index, whether and the SVV and the pulse pressure variation, the cardiac index. Yes, these are all dynamic this thing. And yes, if we have given fluids, the cardiac index has improved. So definitely we assume that tissue perfusion will improve and oxygen delivery will improve to the tissues. Unless until
Thank
we
you so much.
can directly measure submucosal pH, and all those things, these are still not widely accepted. But yes, maybe when these are more acceptable and widely available, I would be in a better condition to answer your question. So probably you can conduct a research whether to see that an increase in cardiac index will improve the mucosal pH, and the we know that it does reduce the lactate values. Sorry.
Thank you so much, sir, for answering all the questions. That was the last question for today's session, and I would like to thank all the viewers for their ardent participation that they have shown by being here with us throughout the session. I would also like to thank you, sir, for taking out your valuable time and for being here with our platform and sharing your wonderful input and contributing with our auditors who are here present with us. And we hope that we could help them in their daily clinical practices. So thank you so much for that, sir.
Yeah. Thank you so much.
With this, sir, with all your last comments, we can conclude the session here for today.
Okay. Thank you.
Thank you, sir.